Hello. Hello.
Hello. Yeah, hi, sir.
Hello, sir. Hello.
Sir, can you hear us?
Yes, yes.
Hello.
So, hello.
Hello, sir.
Yeah. So we have seen variety of sinus cases with different varieties of turbinate, septum, cellularity in the frontal sinus, intersinus, supraorbital, type 3, agonese, all variety of situation we have seen
Yes.
almost. And this case, the case now which we are going to show you is going to complete with one of the most difficult situations, I would say, and interesting variety for everybody. Now, let me play this CT scan and show you what exactly this is.
Okay.
Are you getting on screen something?
Yeah.
See this. And we are thankful to Dr. Sethi, who is going to join us soon. Has he joined? Dekhna.
No.
So, this page, we have seen the cells which narrow the frontal outflow from medially, from laterally, from anteriorly.
Okay.
Now is the situation where the frontal outflow is compromised by a cell from behind. See this.
Yes.
This is the two frontal sinuses
Yeah.
going behind.
Going to,
Can you
yes.
see this intersinus septal cell?
Sure. Yeah.
Where it is opening, keep an eye on the cell. See, it is opening on the left side.
Yes.
Okay?
Yeah.
Now this is frontal sinus. See this, this was frontal sinus.
Yes.
In the frontal recess region, see this cell coming up.
From behind.
Yes, from behind.
Yeah.
And now see this cell behind.
Yes.
Behind. So it has narrowed the frontal drainage from behind. See how this cell
Yes.
in the frontal recess. Now, what exactly this is and how to look at it?
In sagittal plane.
Yeah, that will require a sagittal cut, right?
Right.
See this? The frontal sinus
Yes.
and this cell. Let me bring my cursor into this cell. Can you see here?
Yeah.
And see this. This cell. Amazing. Can you see this frontobular cell?
Yes. 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 That is extending from the
Right
posterior
into
side.
yes, in the frontal sinus,
Yes.
attached to the posterior wall, that is skull base,
Yes.
and has narrowed the frontal sinus drainage pathway from behind.
Yes.
You can't afford to go behind this cell.
Yes.
Otherwise, you'll end up damaging the skull base.
Always.
See this? This is the beak.
Big.
This is the frontal sinus drainage pathway. And this is narrowed by this cell which is attached to the posterior. Classical frontobular cell.
Cells.
So that was the only variety left, which is now with us in this situation, in this case. And interestingly, but our technique of frontal sinus, opening is not going to change. See this? Go along the beak, go along the beak, go along the beak, and your frontal.
Yes.
Can you see?
Yeah. Clear.
Don't fall into anything XYZ. This will always remain the same. But your frontal outflow, when you'll open, will be narrow and there will be a cell behind.
Yeah.
Imagine endoscopically. You open your frontal and you have a narrow opening.
Yes.
And behind is the cell, and you have to open up this cell wall now. You have to deal with this differently.
Yes.
You have to open up this cell wall and flush with the skull base. See that?
Yes.
To give a wide drainage. So that's a real interesting anatomy in this particular case. हमने ज्वाइन किया है क्या? नहीं सर, अच्छा पाए तो मेरे को बता देना। ओके सर, जो
Hello. Yes, sir.
Yes, sir.
Hello.
Sir, good evening.
Good evening.
Sir, yeah, this is a very interesting situation to, before we call up this workshop, to add on to the variety of what we have seen during last 2 days in the frontal sinus. This patient, see this. That is the frontal sinuses on both sides. As I go behind, left side is the intersinus septal cell which communicates to the left sinus. See this?
Yes, clear.
Now, on the right side, see this is the frontal sinus on the right side, and as you go behind, a cell comes. See this cell. See this cell
Yes.
and occupies completely till the skull base. Now, let me reconstruct to the multiplanar view. This is so interesting. See this cell? If I bring my cursor into this cell and see this, This is a classical frontobular cell. Can you see this?
Yes.
And this cell is attached to the posterior wall or to the skull base. This is the beak anteriorly, this is the frontal outflow, and this has narrowed the frontal outflow from behind.
Yes.
Now, this cell we can't afford to go behind and fracture it out. This is the cell attached behind, attached to the skull base, going up. So, our technique of frontal sinus entering into the frontal sinus is going to remain same. See this? Follow the beak where the beak ends into the frontal.
Yes.
But we'll have a narrow opening as we have a cell behind. See this? So,
Yes.
moment we open it, we will find this cell. We have to open up this cell. We have to open up this cell to widen the
Widen the-
frontal outflow.
Yes.
That is classical frontobular cell we have, which has narrowed the frontal sinus opening from behind. Satish sir,
Yes.
this is the situation we have on the right side.
Yes, Satish.
So this is something interesting wherein a cell from behind is narrowing the frontal outflow and should be dealt with differently. As we know now from the sagittal, we can't afford to avulse this cell or go behind it. This has to be opened from front, and then the septation should be flushed with the posterior wall of the skull base. Hello?
Hello.
Yes, sir.
Sir, do we encounter any difficulty in finding this anterior sphenoidal artery in this case?
Not really. The anterior frontal artery is far behind.
Okay.
Nothing to do with the anterior frontal artery.
Okay.
Satish, can you show the anterior sphenoidal artery on the CT scan?
On the axial, on the on the coronal.
You see on the coronal, then you can see it right on the multiplanar 3
Okay.
visible.
Yes. Yes.
Yeah, there it is.
Yes.
Yes.
You can see the anterior frontal artery here.
Yes.
And then put your cursor there and
Yeah.
reformat. Okay.
Yes, yes.
And remove the cursor now.
Yeah, that is the level of the anterior frontal artery.
Okay.
Yeah.
Okay.
And now see. Oh,
You can see that now.
yeah, see this? And that is, behind this,
Frontobular cell.
yes,
Yes.
see the level of the vessel.
And the beauty of this DICOM viewer is that you can create, create multiplanar cuts and see it in all the different views.
See, this is your frontobular cell.
Yes.
And this vessel is behind that, caudal to it. So once you see, we are working for the frontal sinus here.
Yes.
Yep.
Now, frontal artery is miles away.
Exactly.
We need not to, all the time think of anterior frontal artery while working in the frontal recess. Don't need to, So here we will demonstrate right side, which is a it's right here interesting. इसको तो लगवा थायराइड को, उनको चालू करो और यहाँ उसको ले लेना, यहाँ उसको ले लेना। हेलो,
Hello, sir.
yeah, see the multiple polyps.
Yes.
Check. With no space, full of polyps.
Decongestion has been done, sir.
Yeah, initial topical, but there's no space, still full of polyps. Can't see anything but polyps.
Initial debulking is required, sir.
The polyps are looking like infected also.
High DNS, sir.
Yes, high DNS, infected polyps. A lot of issues. Find out.
So we'll correct the DNS first, sir.
Yeah, I think we'll have to. This will not allow us to do a proper job otherwise.
Yes, sir. Instrumentation is difficult.
Yes. Significant deviation. See the opposite side. See? Oh, the situation is challenging. A lot of infected polyps, no visualization inside, deviation significant. See, these are angry polyps, pure inflamed polyps.
So it's a hurdle race, sir.
Oblet. Oblet. See, this is what happens in neurostasis.
So patient has DNS on both the sides, sir.
Pardon?
Patient has DNS on both the sides.
Yeah,
He's S-sepid.
yeah, it is deflected. Anyway, वो है क्या कोलोरेडो नीडल कुछ इसके बाद है क्या This is the condition of polyps.
Yes, sir.
They are quite inflamed. पतले कर इसको, पतले कर.
This is the common problem here, sir. Patient usually doesn't take medicines. He thinks I'm going to be operated, so why to purchase medicines?
पतले कर. So far the preparation work is going on.
Yes, sir.
Can see the challenge. Massive disease, infected. Septal deviation. biggest problem is the inflammation.
Yes, sir. And that will cause bleeding.
Hmm. Nice. फिर पकड़ लो हैं? Good man. हमको बोलना है ये तो बीपी टू हाई मैन. Okay. So adding on to the problems, the BP is very high.
Another hurdle, sir.
Not the wrong. That is responsible for the So it is corrected to certain extent. See the level of oozing from the cut margin. See now the condition has improved. Look at the opposite side. Hello. Hello. Hello.
Hello, sir.
Hello.
See the condition on the opposite side, it has improved. And we have, see right from top to bottom. You have good visualization now.
This is right side, sir.
Your right side. See this?
Yes. Yes, sir.
So it's much better now. Problem. See, we have to manage bleeding all the time. There is no answer to it.
Yes, sir.
Divider. See, the high deviation is corrected on this side. See this?
Yes, sir.
Very clear. Earlier there was no space to enter into.
Yes, it's good now.
See the massive polyposis, no landmark.
Yes, sir. Everything has transformed into polyp.
That looks like Uncinate, but no definite landmark for anything so far. Yes, now I can see
That's look like
this
middle
is the
turbinate.
uncinate process.
Yes, sir.
This is the axilla and the middle turbinate. Can you see?
Yes, sir. Bony part of the middle turbinate. Yes, sir.
And see lot of disease medial to it. See that? Lot of disease in the olfactory cleft.
Yes, sir.
That looks like middle turbinate, sir.
Yeah, this is middle turbinate only.
Yes, sir.
See the level of axilla. See this?
Yes, sir. Yes, sir.
There is a lot of disease medial to it. See a lot of disease medial to it.
Yes, sir.
Again, I am not going to be very aggressive over that.
Yes, sir.
And this is your Uncinate. So things are much clearer now. Challenge persists with inflammation, difficult situation. There's no section. Lost. Like that. See this?
Yes, sir. Bleeding will be a problem in this case.
No problem. We'll see. Now. See, this is axilla.
Yes, sir.
Hmm.
So, sir, what is the dilution of ADR in this case for packing?
Yeah, the same because the patient is hypertensive. We cannot give.
Okay, sir.
Yesterday also we had a hypertensive patient.
Yes, sir.
So far what we have achieved, we have done high deviation correction.
Yes, sir.
We have divided the polyp.
Yes, sir.
See the opposite side. See the incision line. Give me a miracle. Much better now. And we have achieved polypectomy. We have achieved visualization of the middle turbinate and uncinate.
Yes, sir.
And see this middle turbinate there medially. And there is a lot of disease. Lot of disease above the level of the middle turbinate,
Yes, sir.
warranting its partial resections. Okay.
Yes.
I put one mirror cell in the olfactory recess. So interesting case.
Yes, sir. Very interesting.
Chota the mirror. So, mirror cell chota. And now we'll start our sinus surgery step. See now,
Yes, sir.
all set to start the sinus surgery step.
Yes, sir.
See this.
Yes, sir.
Much better now.
Yes, sir. It looks better.
See how important is the preparation. You have to have patience as well.
Yes, sir.
Later. See, all these are maneuvers to improve your field visualization. See now?
Yes, sir.
Now give me reverse biting. I know wherever I bite, it is going to bleed.
Yes, sir.
See, that's the uncinate everted.
Yes, sir. Not much disease in the maxillary antrum, sir.
Yeah, not much. Challenging situation, boss. So this is the lower part of the uncinate. कट दिया करने आ रहे हैं.
Lower horizontal part of the uncinate.
Yes.
Mucosal edema is there, sir.
Yeah. This is the upper part of the uncinate.
Yes, sir. The vertical part.
Give me a cut. This is the middle metal introspect. It is so much inflamed, boss. Every time you have to be careful.
Yes, sir.
But don't go without identifying the landmark further. In spite of whatever situation, you have to identify the landmarks and then move on.
Yes, sir.
Without that, it's dangerous. Operator. Because wherever you touch, it is going to bleed. Doesn't matter. We have to go accordingly.
So the coblation is very useful tool here, sir.
Population we always keep in every sinus case. Some or other time it is required.
Because this much of bleeding won't be taken care of by cautery.
Water is traumatic.
Yes, sir.
Now see what I have done.
Wide middle metal in the
Millimeter and 12.
Yes, sir. The wide opening. No polyps inside, sir. No fungal wall.
No, that we knew from the CT scan.
Yes, sir.
These are vessels.
Yes, sir.
Then, problem. So, you mean through biting. Through biting is straight. Suction. See, I am creating a mega middle metal enterostomy.
Yes, sir. Extending it posteriorly.
Yeah. Looking at its disease profile. See now,
Yes, sir.
wider than the usual ones.
Yes, sir.
Now this is the upper uncinate. See, every time you have to deal with the bleeding like this only.
Yes, sir.
That is the upper uncinate.
Am I getting the lateral boundary, sir?
Yes, that is the bony plate.
Yes, sir.
Like that. See the middle metal enterostomy.
Yes, sir. It's the wide end.
See, by means of using Merocell packs and all these measures I am using for the hemostasis, at the end of the surgery, you will see the same picture.
Yes, sir.
and all that. Yes. See what it is?
Clearing the
Level
axilla.
of the lamina pepracia.
Yes, sir. Laterally lamina is cleared.
Yes. That is the level of the lamina pepracia. Let me clear you better.
Yes, sir.
That is your lamina pepracia. Can you see here?
Yes, sir. Very clear, sir. Except some bleeding.
Yeah. See your level of the lamina in the beginning.
Yes, sir.
Doesn't matter this little bit of the bleeding, whatever. But and see what I'm going up towards the
Yes,
axilla,
yes, sir.
flushing the lamina. What a landmark it is.
Yes, sir.
Flushing the lamina, you can go high up without any fear. See this?
Yes, sir.
See, I've debrided all these polyps. Clear the sphenoid little bit to reduce the inflammation. See, now I have ample of space.
Yes, sir.
See this?
Yes.
See this?
Yes, sir. Lateral wall is clear.
Yes, you can orient yourself, find out. You can orient yourself.
Yes, sir.
That's the sphenoidal cavity, that's the lamina pepracia, maxillary sinus below. See this?
Yes, sir.
More and more anatomy is opening up.
Yes.
Go beyond. This is your part of the turbinate. And this is all eosinophilic secretion and disease.
Yes.
Right. Our challenge is the frontal here.
Yes, sir. As you mentioned earlier, on the right side.
Yes. That's why I took up right side first.
Yes, sir.
In spite of being deviation, because we may not show both sides.
Yes, sir.
Time constant, so at least we should show the important
Yes.
side.
Okay, sir. So this is going to be the last case, sir.
Yeah, looking at the time.
Okay, sir.
And a lot of people are saying there is India-Pakistan cricket match today. Want to see this?
Yes, sir.
See now the picture.
Yes, sir. Pretty much clear.
In spite of all odds,
All hurdles.
2/2. So what I will do first, as usual, as I said, to the turbinate.
Yes, sir. Yeah, resecting it, sir.
Yes. Partial resection, you know.
Yes, sir.
Give me the brighter. The lower part will take later.
Yes.
Right now, my focus is above.
Yes.
This turbinate is our limit. See?
Yes, sir.
And this is at the level of axilla to look for
Beak,
beak.
frontal beaks.
Very interesting anatomy coming up.
Yes, sir.
So far, I was doing with a 0 degree. You
Yes,
see, my corridor has opened up. See this?
yes, sir.
My medial and lateral limit you can see, and anteriorly I am reaching towards the beak
Yes, sir.
without any issues. And now this is the time, give a pack.
So it's 70 times, sir.
Now it is 70 time. You're right.
Time for 70 degree.
Yes, yes. Now you know each and every move. Every time you are saying what I'm going to do next. So you're right. It's a time for the 70 degree now.
70 show.
Yeah. And let me decongest it very well because the frontal part I want to show properly.
Yes, sir.
Conditions have improved.
Yes, sir. Much clearer than before, sir.
Imagine initially how depressing was the condition.
It's all about patience, sir.
Okay. Give me 70 now. So what? Remember the CT scan. ले लेना. हाँ. Remember in the CT scan what we are expected to see here.
Narrow opening of frontal
Yes.
and posterior cell just
Yeah.
behind the opening.
Yes, exactly. See something.
That's the cell, sir. Yes, sir.
See the frontal
There's a frontal opening and the cell behind it.
and the cell. See this cell which is narrowed.
Yes, sir.
See this cell. I will go and break it
Yes,
like
sir.
this.
Yes, sir.
See this? See the cell which has come out?
Yes, sir.
See the partition which has come out?
Yes, sir. Yes, sir.
You have to flush it with the skull base. See this?
Yes, sir.
This is, and that is the frontal.
Beautiful picture, sir.
So this was the cell which was obstructing, which I am removing.
Yes, sir.
And it was attached where? Posteriorly to the skull base. Could you
Yes, sir.
see?
It is a large cell, sir.
Yeah. Could you see? This was attached posteriorly.
Yes, sir. Yes, sir. Just
I will
making
again-
the opening narrow.
From behind.
Yeah, from behind. Yes, sir.
It was not attached anteriorly. That is important.
Yes, sir.
Let me show you once again. I will tell you, everybody. Give me over there. 1 minute. Let me widen it and then show you. You will never forget. Remember with the curate, how did I break that cell?
Yes, sir.
Towards me.
Yes.
वो देना बॉल प्रो let me clear it first thoroughly and then the remnant of the cell laterally. See this?
Yes, sir.
See how nice the frontal opening now.
Very beautiful, sir.
Now let me tell you. तो वो दे मेरे से तो हाँ बोल दो We'll see the structures anterior to posterior like I had shown on the CT scan
Yes, sir.
in the same way.
Yes.
Is Satish sir there online? Now, is Satish sir there online?
No.
Yeah, in Singapore, it is quite late now. See now, the first thing anterior to posterior, I showed you the beak. See that?
Yes. Yes, sir.
Then the narrow frontal sinus opening.
Yes, sir.
Then there was a cell which was extending from there to the
Yes, sir.
base of skull.
Skull base.
And
Yes, sir.
I fractured that cell and flushed with the skull base
Yes, sir.
to widen this opening. Got my point or not?
Yes.
Simple.
Yes, sir. Yes, sir. Absolutely clear, sir.
So that was a situation where the cell was obstructing from behind. And see the full frontal sinus, widest possible sinus
Yes, sir.
opening.
That was a tricky situation, sir.
See how good it is. We have lateral limit, we have medial limit, we have anterior limit, and we have a skull base.
Skull base. Yes, sir.
Now, finally, give me reverse. Okay.
It was a left side. ठीक है मैं उधर आपको ठीक है तुम भी मेरा मेरे को टाइम लगेगा
ठीक है ठीक 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 डन now the reverse same
Yes, sir.
and flushing with the
Skull base.
sphenoidal skull base.
Yes, sir.
With the reverse blade.
Yes, sir. Is that the artery, sir?
This is no. See this. Flush with the
Skull base.
yes. See with the posterior sphenoidal skull base, anterior sphenoidal skull base. This is very safe. This gives you full access to the frontal sinus for drugs to go there. Drugs to reach out there. See this?
Yes, sir.
See the frontal, how big it is now
Yes, sir.
on such a difficult situation. Zero. Quick now, we'll finish in next 5 minutes this side. Oh, that should some straight there. Imagine the situation. Where is that?
Bleeding has reduced a bit, but still there is.
Yeah. It will come under control. See the moment I finish this surgery, everything will stop. Now I am not much bothered about that. See the maxillary sinus? See the medial orbital angle? Can you see this? See the roof of maxilla. Clear? See the roof of maxilla.
Plexus? No,
See the roof of maxilla? Pretty clear? Hello?
Hello, sir.
Yes.
So you've cleared the medial orbital angle, sir.
Yes. Cleared.
Yes.
Mr. Satish sir is joined. Satish sir?
Yes, Satish, I'm here.
Yeah, we cleared the frontobular cell
Yes,
and see the frontal sinus with 0 degree.
beautiful.
So it was a frontobular cell like we saw on CT scan attached to the posterior table.
Mhm.
And see the entire
What a
cavity now.
difference. What a difference from when you started, huh?
I'm used to
What a difference.
such situations, you know. This part of the turbinate lower down we have to remove. I left for the end. See, this is superior turbinate there. Can you see very clear?
Yes, sir.
That
Medially
is
the septum.
yeah. This middle terminate below I am going to remove later. This is superior terminate, lower ones. And now see the anatomy. At what level I am in the, see this level, I will be going inside the sphenoid sinus. See, that is sphenoid sinus.
Yes, sir.
See this?
Yes, sir.
Exactly there.
Yes, sir.
Can you see? That is the value of this landmark. Now give me pack for a while. So now I've got the important landmark, sphenoid sinus, and in no time we'll be finishing it. Record it. Record it. Code section. Take all these measures to improve the visualization. Later. Oh, lastly, yes, the brighter. Yes, now that is our sphenoid sinus, you can see there.
Yes, sir.
Keeping that in mind, I have to clean this entire posterior mold. You know, only this mechanism point done.
Is that a Haller cell, sir?
Yeah, could be.
The rotate will one the last person.
मेरी मर्जी
ये तो पूरा 5 मिनट में करते हैं
पता नहीं
ये नहीं हो जाए
कैसे करनी हो लगा तो जो भी लगाना है this
We are flushing.
the skull base, posterior
Yes,
model skull base.
Yes, sir. Flushing it with skull base.
Fast. No, पानी मत डालना. And see this, I have to join this. Clean. Ah. That is the posterior skull base.
Yes, sir.
This is posterior. This is sphenoid sinus opening.
Yes.
And I have to join this. I have to complete staying anterior to it. This posterior first. See this.
Yes, sir.
This is posterior. All this posterior. See this?
Yes, sir.
So Satish, is the red 40 you're using?
Right now, straight.
Straight, okay.
See, sir, I'm just completing the straight posterior.
Yeah, I see that.
And now this is my party wall.
Yes.
Widening the sphenoid wall. See, now the posterior is complete.
Yes, sir.
The only thing left is widening the,
Sphenoid ostia.
yes.
Laterally, the lamina is clear.
Yeah. Entire posterior. See the skull base coming from above.
Yes, sir. From above skull base, laterally lamina, all clear.
Yeah. Give me the pack for a while.
Bleeding is not going to forgive us, sir.
Yeah, no, this is not going to. Now hardly any bleeding. How it is going to bother us now? We are finished.
Yes, sir.
नीचे वहां मत. Just let it be for a minute and see the skull base.
Almost flush, sir. That is complete full house face, sir.
Yeah, so this patient offered so many challenges. Hypertension, inflammation, septal deviation, significant deviation, massive disease, challenging anatomy.
All the possible combinations.
Mhm. This is the part of the middle terminate I left for the
Yes.
end. Which I left for the end.
Yes, sir. Actually, sir, the angiofibroma case has less bleeding than this case.
Yeah, you can say. Angiofibroma was in the angiofibroma category was a cakewalk.
Yes, sir. But the name is scary.
Yeah. This is the rest of the middle terminate work.
Yes, sir.
After utilizing this as a great landmark, and see this part of the terminate is there up and not below. So that it doesn't obstruct our
Olfaction.
olfactory area.
Yes, sir.
Frontal. ये दिल डाल, हाँ. पकड़ ले इसको पकड़ के रख. छोड़. Yes. यहाँ पकड़ ले. See now the final work, Carison. नीचे कर ले, इधर इधर इधर. Now final work is going to be widening this. See this anterior wall?
Yes, sir.
Thick bones.
Yes, sir. Osteitis.
Yeah, such a thick bone. See this?
Yes, sir.
Widen the sphenoid. This is important. No, red 40 there. See the sphenoid?
Yes, sir. Very wide opening, sir.
Now,
एनएस अब्दुल एनएस दो इसमें
operation में.
Is that the part of uncinate, sir, that is left?
Pardon?
Is that the part of uncinate that is left?
This
here?
one?
Yes. This,
No,
yes,
no,
sir.
not uncinate. Part of the posterior end of the middle terminus,
Okay, sir. Okay, sir.
which I have not cut yet.
Okay, sir.
Now see the interior of the sphenoid,
Very wide, sir. Opening.
all posterior sphenoid, everything crystal clear now.
Yes.
Just action. We'll just irrigate for a minute or two and everything will be perfect. All will come back to scissors. See this part of the terminate stump.
Yes, sir.
See the vessel?
Yes, sir.
The branch of the sphenopalatine coming to the middle turbinate. See that?
Yes, sir.
See the vessel? This is responsible for the middle turbinate flap.
Yes, sir. So this bleeder was the last hurdle, sir.
No, वो दे मेरे को बस डालने के लिए पानी धार बना के. See now the final picture. See this?
All the sinus corridor is very clear, sir.
Ultra clear, everything. Our job is complete on this side. See that? Out.
And the bleeding has stopped, sir.
Yeah, it is. It is bound to. See now, the picture is good.
Yes, sir.
Just we'll pack this side and this is full house fest. See the right from the frontal, both medial and lateral limit, we left the disease in the olfactory cleft and did a partial terminate resection as a part of our strategy.
Yes, sir.
See this?
Yes.
This disease in the olfactory cleft.
Yes, sir.
I don't want to, traumatize this mucosa. What my point?
Yes, sir.
So this is all about this side first and So that will be end of the demonstration today. Probably we have though 3-4 cases in the theater to finish off, which were planned and could not demonstrate. But the official workshop comes to an end over here. Thank you very much for your attention, and big thanks to Dr. Farooq for making this happen and giving this opportunity. Big thanks to Dr. Sethi also for sparing his valuable time and his comments.
Thank you, Satish, and thank you everyone there. Really had a wonderful day today. So all the best. Bye.
Thank you so much, sir. Thank you, Farooq boss, for arranging such a wonderful series of cases. We have seen all the variations of frontal sinus. So now we are more confident in frontal sinusitis. Thank you so much, Satish Jain, sir, for a wonderful demonstration. Thank you so much, sir.
Thank you, sir.
Sir, can we close the live?
Yes, Dinesh ji.
Okay, sir.
Hey, is Farooq there? Can we hear from Farooq?
Farooq, sir, I'm going to call.
लो पूछ रहा है दिनेश.
हाँ नहीं क्लोज करवा देते हैं ना. हाँ दिनेश बोला नहीं जाता है यार. मेरे को क्या होता है
बस मेरे को चादर थी ना.
हाँ सर. एक मिनट सर, मैं आपको लगाता हूँ, कैमरा ऑन कर दो.
टेबल का है केस लेगा और
हो गया. सब केस लिवा गया.
हो गया सब.
सब लिवा गया. पेरोटिड अंदर है. ये है नेकलम. उधर थायराइड कर रहे हैं. बस केस खत्म. हेलो.
Yes, sir. Yes, sir. Hello, sir.
Yeah, Dinesh. Hello.
Yes, sir. So I'm stopping live, sir. Yeah, just continue, sir. Yeah.
Let me take the opportunity to thank everybody for their presence, taking out their precious time to spare in this workshop. And I'm sure all of us have enjoyed, as well as our national and international viewers. It was a fantastic treat to watch Dr. Satish Jain performing a variety of surgeries, especially difficult frontal cases. So we had around 8 first cases, and all of them had different variety of frontal. We saw supraocular cell. We saw different types of variety, and I'm sure that we have cleared many of our doubts. So that brings us to the conclusion of this workshop. And at the end, I thank you all once again for your active participation, feedback. Thank you.
Thank you, boss.
Thank you.
Thank you so much.
Thank you, sir. We are stopping live, sir.
Thank you, Dinesh.